The ACA 2026 guidelines introduce a 5-tier clinical classification system for acute pulmonary embolism, labeled A to E. This system integrates clinical severity scores, hemodynamic status, respiratory status, biomarkers, labeled right ventricular imaging to guide decision-making. Category A represents subclinical pulmonary embolism, typically incidental findings on imaging in asymptomatic patients. Category B includes symptomatic patients with low clinical severity, defined by SBESI of 0 or HESTA score of 0. Category B1 includes subsegmental pulmonary embolism, while Category B2 includes segmental or more proximal embolism. Category C includes symptomatic patients with elevated clinical severity, defined by SBESI greater than or equal to 1, but remaining hemodynamically stable. Category C1 shows normal right ventricular function and normal biomarkers, while C2 shows either abnormal right ventricle or abnormal biomarkers. Category C3 represents both abnormal right ventricular function and at least one abnormal biomarker, such as troponin or BNP. Category D represents incipient cardiopulmonary failure, also described as a pre-shock state with high risk of deterioration. Category D1 includes transient hypotension that responds to fluids, while D2 includes normotensive shock with end organ hypoperfusion, such as lactate above 2 mmol per liter or acute kidney injury. Category E represents overt cardiopulmonary failure with persistent hypotension, cardiogenic shock, or cardiac arrest. A respiratory modifier R is added when severe hypoxemia, tachypnea, high oxygen requirement, or mechanical ventilation is present. The key takeaway is that this classification standardizes pulmonary embolism severity to guide triage, treatment intensity, and advanced therapy decisions.